Then the next investigation would be IV pylography. What you will do, intravenously you will pass a contrast and it will then appear into the pelvic ileal system and pass to the ureter and reach the bladder. And you will delineate by taking serial films how is the passage of the dye. If you want to define the extent of urinary tract obstruction, how much hydronephrosis is there because of this bloody stone, then you need to do IVP. It is not needed for the screening. Suppose you are clinically suspecting stone, you need not get an IVP done. You can get a plain radiograph done. It is not necessary for the diagnosis of the renal caliculi. It is mainly to decide after the calculus is being discovered, shall I do lithotripsy? Shall I do percutaneous removal? Which procedure shall I choose? I want to do to take care of this stone. Then to delineate the anatomy when you are doing a procedure, you require IVP, is what you need to remember. Then renal ultrasound. How will it help you in a stone patient? It can detect the hydronephrotic changes, hydroureter, etc., etc. It can be able to visualize. But problem is, in the early phases, hydronephrosis, when it is mild, it may not be picked up by the ultrasound. That's a pitfall which we all need to agree. If there is a hematuria plus pyuria, that means already stone led to the development of a concomitant infection. And always, if the stone is passed into urine, ask the patient to bring it. It is as important as the Kohinoor diamond, because you want to do chemical analysis of that stone. Is it calcium? Is it urate? Is it cystine? What kind of stone it is? And that will help you a lot in deciding the ultimate treatment. First thing is treat the pain. You can give morphine, parenteral NSAIDs, give adequate hydration. If UTI is there, give antibiotics. And when do you want to admit a patient of renal colic? If pain is not controlled, if there is an anuria, if there is a UTI plus renal colic, and if there is a very large stone more than 1 centimeter, when you have done imaging, you discovered a staghorn calculus, you can't ask patient to go home and sleep. You need to admit him basically. Now, what are the important measures? Mainly pain. Mild to moderate pain, if he takes good fluid, oral analgesia, and wait for the stone to pass, acceptable. If it is a very severe pain, you need to give IV fluids, control the pain, get a KUB and IVP, and if the stone cannot pass after 3 days, then that becomes an indication for surgery to remove the stones. Now, what are the options available? You can do a very simple procedure, extracorporeal shock wave lithotripsy, which will be able to break the stone apart, and once the calculus is fragmented, obviously it will pass spontaneously. That is the idea of doing a extracorporeal shock wave lithotripsy. But what is the size criteria to select a patient for this procedure? Any stone which is more than 5 mm but less than 2 centimeters, that is 200 mm, is the best one. In order to, that kind of a patient is the best one to undergo a shock wave lithotripsy, is what need to be remembered. What do you do in this? Make the patient to lie down, and you will be passing a shock wave, and those waves will break down the stone, and that smaller pieces will then pass through the urine. So that is the whole idea. Of course, in surgery we will discuss in more detail. Location of the stone, which will decide which measure of which type, and all those things we will discuss more in surgery, but at least you should have working knowledge in general medicine. Second choice available for you is percutaneous nephrolithotomy. What is the meaning of it? Have you played kites? It's like playing kites or doing fishing and catching the fish kind of a job is percutaneous nephrolithotomy. In this, what will you do? If the stone size is more than 2 centimeters in diameter, then you will give one small incision, you will make a tunnel, and you will be reaching the pelvic ileal system. You catch the stone and pull it out. through the percutaneous catheter, which is basically called percutaneous nephrolithotomy, is what need to be basically remembered. Then most important when the patient leaves home is tell him about how to prevent the recurrences of renal stones. High fluid intake, limit animal protein, limit calcium intake. Which foods contain the calcium rich in SPM you study, no? There you thought it is useless information, but it is definitely useful here. All that SPM knowledge somewhere or other will help. Nowhere it will help, at least it will help in one location. If you build your own house, what kind of septic latrine to be planned is very well taught in park preventive medicine. At least if you don't have practice, you are being bitten by mosquitoes sitting in the OPD, you know whether I am going to get dengue because this mosquito looks like this, it's a tiger mosquito. No, it is that female, beautiful, curvaceous Anopheles, hence I am going to get malaria. And one more place where it will help you is ultimately no practice, no home, no chance of even building septic latrine, you are depressed, you want to die, you can decide organochloride or organophosphor. And what are the side effects of each of them? So there are last 150 pages of park, most useful part in the entire life, right? So doctor, I leave to you which foods to eat and all those things, the nursing part of general medicine at a later point. Now, is there any way we can pharmacologically treat? You know, loop diuretics enhance the calciuria. Thiazide diuretics increase the reabsorption of calcium and decrease the calcium content inside the tubular fluid. Hence we can give thiazides. If it is urate, we can give allopurinol, is considered to be the part of the medical management. Now doctor, that is all the story. So what are you going to write in the tomorrow's exam? 5 sweet lines. Nephrolithotomy, size criteria of the stones, two white stones, calcium stones, common location where they obstruct, high fluid intake, bus, belly is over. You are done with the 5 marks, 5 points essential for MBBS final exam. Now doctor, urinary tract obstruction, let us talk about it. The obstruction of tract can lead to renal insufficiency, it can lead to hydronephrosis with the dilatation of the urinary tract, especially pelvic ileal system. Very common in the men. Why? Men only have prostate and that can enlarge in the form of BPH or prostate cancer and can obstruct the prostatic urethra, and that can lead to development of an increased back pressure and lead to development of a lower urinary tract obstruction. Hence more common in the men. Now, urinary obstruction, hydronephrosis, somebody presents to you. Will you immediately tell, "Arey, your kidney is blocked, you are going into renal failure"? No. Urinary obstruction does not usually cause ARF unless the obstruction is bilateral. God luckily gave 2 kidneys, only 1 liver to drink limited alcohol, and 1 heart to donate anybody. Because if it is 2, then there is a confusion. So 1 kidney gone also. Some people will be born with single kidney, let me tell you. They will live happily, they become president of the country, and then they will inaugurate so many kidney centers. One fine day when you do ultrasound, you will discover only 1 kidney, nothing to worry about. So ARF doesn't occur unless it is bilateral obstruction. Can you give me a reason why bilaterally obstruction can occur? Suppose if there is a retroperitoneal fibrosis, ureters being retroperitoneal structures, they can be obstructed bilaterally, is what need to be remembered. Then you must know, is it acute or chronic? Is it unilateral or bilateral? Is it lower urinary tract or upper urinary tract? You need to differentiate whenever there is a UT obstruction. So lower urinary tract begins from there. You have a ureter ending in bladder, no? Below that, what you have? Ureterovesical junction, then there is a urethra. Anywhere the obstruction is called lower urinary tract obstruction, and above the level of the ureterovesical junction you call upper urinary tract obstruction. is what need to be remembered. Now, what are the causes of lower urinary tract obstruction? You all know, BPH, prostate cancer, any stricture of urethra, as what you can see, this is the normal urethra and this is the strictured urethra. It can occur when a person has a trauma, or if the person is having a gonorrhea like infections which can lead to the development of stricture. Any stone can form in the urethra. Then neurogenic bladder, bladder cancer, anything can lead to lower urinary tract obstruction. What they cause? Above the level of the uretero-vesical junction, stones, very common cause. Sloughed papillae, then tumors, strictures. Some people have a peculiar problem called uretero-pelvic. This is the pelvis doctor. Uretero-pelvic congenital stricture people will have at birth only, and they will be diagnosed with hydronephrosis, UTI, and pyonephrosis, pus in the kidney. Once they reach that ultimate stage, then when you evaluate, you will discover that they have a congenital uretero-pelvic junction stricture, is what need to be remembered. Similarly, pregnancy, tumors, aortic aneurysm, retroperitoneal fibrosis, endometriotic implants, or any hematoma, any of them also can lead to development of extrinsic causes for the development of a upper urinary tract obstruction, is what I want to underscore to all of you. So how do you evaluate? Symptom duration, history of stones, history of any surgery, any suprapubic mass, features of CRF, etc., etc.